Prostate is a walnut-sized gland that surrounds urethra and present at the base of urinary bladder. It is part of the male reproductive system, and its main function is that it secretes fluid, which becomes part of the seminal fluid which contains sperms. Prostate is dependent on androgens for its development, maintenance, and function, particularly the testosterone. Testosterone is metabolized into dihydrotestosterone by enzyme 5-alpha reductase. In case of benign prostate hyperplasia, this dihydrotestosterone causes an increase in the number of cells, as well as the overgrowth of the stromal and epithelial cells, which presses against the wall of urethra and causes urinary obstruction. This urinary obstruction leads towards lower urinary tract symptoms, which include intermittent urine flow, weak stream of urine, urinary urgency, leaking or rippling of urine due to incomplete emptying of bladder, as well as urinary frequency enhancement, especially at night. This benign prostate hyperplasia can be diagnosed by either digital rectal examination or an antigen called prostate-specific antigen. This prostate-specific antigen level increases when there is a prostate enlargement. Treatment of BPH depends on severity of symptoms. Questionnaires such as the International Prostate Symptom Score is used to quantify those symptoms and suggest proper treatment. Treatment include the use of either natural products or the use of FDA-approved drugs. It is important to note that the American Urological Association guidelines does not recommend any natural products. However, there are some natural products out there which claims to be effective for the use of BPH in preclinical studies. These include saw palmetto, lycopene, which is effective for the management and treatment of prostate cancer prevention, rye pollen, and pumpkin seed. Saw palmetto has been used for BPH, but there is little evidence of its effectiveness. FDA-approved drugs can be classified into three categories. The first one being alpha blockers, the second one 5-alpha reductase inhibitors, and the third one phosphodiesterase inhibitors. These drugs can be used either alone or in combination to treat and manage BPH. Alpha blockers are first-line treatment for management of moderate to severe symptoms linked with BPH. They produce quick action. However, there is a need of reassessment after 4 to 6 weeks of therapy. Alpha blockers does not decrease the prostate size and hence doesn't alter the level of PSA, that is prostate specific antigen. Alpha blockers produces its effect by acting on alpha-1 adrenergic receptors present at the bladder as well as prostate neck. By acting on these receptors as a blocker, when they block these receptors, it causes relaxation of smooth muscles followed by decrease in the obstruction and hence improve the urine flow. Alpha blockers can be classified into either non-selective ones or selective ones. The non-selective alpha blockers include doxazosin with a start dose of 1 mg at bedtime which can be increased up to 8 mg, and terazosin with a start dose of 1 mg up to 20 mg maximum dose. The selective alpha-1A blockers are much more effective because they have lesser side effects. Selective alpha-1A blockers include tamsulosin with a dose of 0.4 mg OD, alfuzosin with a dose of 10 mg, and the last one is silodosin with a dose of 8 mg. These doses can be titrated according to individual patient circumstances. The problem with non-selective alpha-1 blockers are that it causes orthostatic hypotension, by pulling the vascular smooth muscles and decreasing the blood pressure. Therefore, it is important that these drugs should be given at bedtime. Similarly, there is another condition called intraoperative floppy iris syndrome associated with alpha blockers because of the alpha receptor's presence in the iris and its interaction with it. Therefore, cataract surgery should be planned accordingly. The last one is retrograde ejaculation, which is particularly linked with the ceridosine. It is a phenomena where the seminal fluid does not go through the urethra and it backs up into the urinary bladder. This condition itself recover after discontinuation of this medication. 5-alpha reductase inhibitors are another class of agents used in the management of BPH. These drugs block the 5-alpha reductase enzyme involved in the metabolism of testosterone to dihydrotestosterone. By decreasing the level of dihydrotestosterone, they decreases or shrink the prostate size and reduce the prostate-specific antigen level. These drugs, however, require a longer time to produce its maximum action, that is up to 6 months. Drugs which belong to 5-alpha reductase class are finasteride, which inhibit type 2 enzyme with a given dose of 5 mg per oral OD. And the second agent is dutasteride, which inhibit both type 1 and type 2 enzyme with a recommended dose of 0.5 mg OD. It is important to note that these drugs should not be handled or taken by pregnant women because they are absorbed through skin and can have detrimental effect on the fetus. Finasteride comes in Propecia, which is the 1 mg dose and given for the management of alopecia, that is hair loss, because it increases the level of testosterone. The last class of agents used for the management of BPH are phosphodiesterase 5 inhibitors. They are majorly used for erectile dysfunction. However, the only FDA-approved drug is tadalafil at low doses for the management of BPH. The exact mechanism is unknown, however, it increases the smooth muscle relaxation and decreases the endothelial cell as well as smooth cell proliferation in case of BPH. Cialis is a famous brand and its dose is 5 mg per oral OD for BPH. So it is an ideal choice for patients suffering from both BPH as well as erectile dysfunction. Some of the major side effects associated with Cialis or tadalafil are hypotension, hearing loss, headache, dizziness, and many more. Overall, the drugs which treat BPH are alpha blockers, 5-alpha reductase inhibitors, and phosphodiesterase 5 inhibitors. These drugs can be used alone or in combination for the management of BPH. Alpha blockers are the first choice for the management of moderate to severe symptoms and they have quick onset. They, however, does not decrease the prostate size and have no effect on the PSA level. On the other hand, 5-alpha reductase inhibitors are very good. However, they require a longer time, delayed onset, but they decrease the prostate size as well as the PSA level. These drugs can be used in combination for the management of BPH. The only FDA-approved drug in this class is tadalafil, which is ideal choice for patients suffering from BPH as well as erectile dysfunction. If these drugs are unable to manage the BPH, then the last resort is surgery. I hope you find this video useful. If you like it, kindly share and subscribe. Thank you.